Okay, let's get started with our local anesthetic lecture and local anesthetic pharmacology 1 and 2. So let's dive in. So local anesthetics are drugs which have a reversible loss of sensation. So we don't want a permanent loss of sensation. That would be medications like alcohol or phenol when applied directly to the mucous membranes or to the nerve tissue, cause nerve damage. And they would be selective for the areas only where they are administered. They would have a rapid onset. They would have a reversible block. They would have a low degree of systemic toxicity. So the fact that drugs have cardiotoxic issues or are CNS toxic is a problem. We'd like them to be easily dissolvable in the solution. So they're easy to inject. So a thick viscous solution is not really what we want. And we would want it to be able to be applied to most parts of the nervous system and all types of nerves and fibers and not have toxicity on one specific group. None of the medications that we have yet are optimal, mainly because they have their toxicities. They are both neurotoxic and cardiotoxic. So the structure from an organic chemistry basis for local anesthetics they are all weak bases. They have this lipophilic portion which dissolves into the plasma membrane, and they have this hydrophilic portion which accepts and donates a hydrogen ion or a proton, and this is what determines the activity level of the local anesthetic. And then there is the chemical family, which is determined by the amide linkage or the ester linkage, and we'll talk about that just briefly. Local anesthetics that have this amide linkage have two I's in the name. Okay, then this is the definition that you probably heard when you first started anesthesia. And what they mean by that is amides are lidocaine, mepivocaine, bupivacaine, atidocane, and ropivacaine. So all the amides have an I in it, just like amide has an I. Ester doesn't have an I. There's no I in team either. I don't know what that means, but coaches used to say that. And ester linkages are procaine, tetracaine, benzocaine, and cocaine. Cocaine is a local anesthetic, while from a law enforcement standpoint, it has classification as a narcotic. It is actually a local anesthetic. And on occasion, that will show up on a test because people forget that it is a local anesthetic. And has local anesthetic properties. It's used to anesthetize mucous membranes in ENT surgery and that kind of thing. It's also used to anesthetize mucous membranes in several social settings, but we won't get into that now. So you have allergies to local anesthetics, and we'll talk about this extensively with some data and some research that's been done. But it tends to occur in the same chemical class. And what I mean by that is if you're allergic to amides, it's usually a group effect, or if you're allergic to esters, it's a group effect. You don't usually have cross allergy to both. It's very rare to have cross allergy to both because they are so different. Now, esters are commonly metabolized to a PABA metabolite, and it is that metabolite that sometimes causes more of an insensitivity than a true anaphylactic response. And remember that whenever we're talking about an allergy, there's an anaphylactoid reaction and an anaphylactic reaction. An anaphylactoid reaction is just mast cell degranulation, whereas an anaphylactic reaction is immunologic memory, where there are antibodies floating around. The first exposure with IgE is not as severe as the second exposure after antibodies have been created with IgG-mediated issues. So the anaphylactoid reactions are more of a histamine degranulation, more like a chronic sinusitis allergy, whereas a true anaphylactic reaction is an immune reaction with memory and is much more severe. Anaphylactoid reactions can have bad consequences, but anaphylactic reactions are bronchospasm, severe hypotension, very difficult things to treat. So a lot of times people will say that they have an allergic reaction whenever it's really an intolerance, or it's an anaphylactoid reaction, which are not great either. But very few people have a true anaphylactic reaction to local anesthetics. Esters are rapidly metabolized in the plasma, so they're broken down by plasma esterases, whereas amides are broken down by the P450 system in the liver. So that's why esters have a relatively quick turnaround, and you don't get a lot of systemic toxicity with ester local anesthetics, whereas amides do accumulate, and they are destroyed by the liver, so that you can have more toxicity problems with amides. And we will talk about toxicities as we go along as well. So local anesthetics have no effect on the resting membrane potential, and that's important to know. So they don't cause the nerve to depolarize more like an opiate does, or to depolarize less like an NMDA agonist would. So they don't hyperpolarize or depolarize the neuron. They merely block sodium channel activity. So they bind inside the cell, and we'll talk about this extensively. You're going to be really sick of how I build this in a real stepwise fashion, but hopefully after I've done this, it will be well drilled into your brain. It is an intracellular binding site that prevents axonal conduction. Okay. Local anesthetics have a great affinity for the sodium channel in the inactivated state. That in and of itself is a hard fact to remember, so I'm going to show you a cartoon that perhaps will give you some reference to hang that on, and so you can see that cartoon in your mind. It's in the inactivated state, and it slows the local anesthetic, slows the sodium channel reverting to its resting state. What do I mean by that? Well, in the resting state, you have the sodium channel, which is closed at the extracellular membrane surface and open at the intracellular membrane surface. So closed here, open here. Now this is as a protein conformation, so it's not like a cartoon like this, but this is a diagrammatic representation. Whenever the nerve depolarizes, reaches the threshold potential, this extracellular narrowing pops open, and sodium is able to rush through, and in a timed fashion pops open, tick, 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 until it is closed, and the sodium channel is closed via this intracellular change in conformation. And then there's a refractory period where it resets. So local anesthetics slow this refractory period, making the sodium channel take longer to reset, and it also binds, holding it open in the inactivated form. So local anesthetics have the highest affinity for this inactivated form, and it slows the reversion back to the resting state and delays opening into the open state, which allows the action potential to be conducted. So local anesthetics bind intracellularly, and they slow this refractory period. And they bind most frequently at this intracellular binding site. So you can already see that the more frequently the nerve is firing, the more avidly local anesthetics will bind, which means that high activity, high firing nerves are more likely to be blocked than slower firing nerves. The action is voltage dependent. Voltage changes induce changes in the form of the sodium channel. So local anesthetics have a higher affinity for sodium channel in the closed form of the channel, preventing them from opening, and an even higher affinity still for the inactivated state. Okay, so whenever you're open, local anesthetics don't bind well. Okay, it is in the inactivated state or the resting state, 1, 2, 3 from an affinity standpoint. Okay, 1, 2, 3 from an affinity standpoint. So that means the voltage dependent form of it is whenever it's depolarized, it's voltage dependent. It's not going to bind well to it whenever it is firing. And it's the highest affinity in the inactivated state, as we just talked about. It's also frequency dependent. As you could see from the previous cartoon, the more frequently the sodium channel is cycling to the open form, to the inactivated form, the more likely it is that local anesthetic can bind. So if it's firing 10 times per second, versus 1 time per second, it's 10 times more likely to bind the local anesthetic and get a conduction blockade. So it is both voltage dependent and frequency dependent. Voltage dependent because it has to be depolarized to form the active state, and frequency dependent because it has to be firing to get there. Hopefully that makes sense. Local anesthetics are weak bases, and access to the receptor site is dependent upon the pKa, the lipid solubility, and the molecule size. Okay, what does this mean? So the pKa determines the charge of the local anesthetic. We'll talk about that. The lipid solubility determines how quickly it traverses into the membrane and out of the membrane. And then the larger the molecule, obviously, the slower it is to act. So the smaller the molecule, the faster it is to act. Local anesthetics act in the charged or cationic form, or the protonated form. So when they are neutral, they do not have activity. Now this is where it gets a little bit difficult to remember. So I'm going to show you a cartoon here in a second that will talk about it, but here are some of the facts. Local anesthetics have to dissolve in the membrane, and they can distort the membrane and alter function. So that's the Meyer-Overton rule of anesthesia, that if an anesthetic agent alters the plasma membrane integrity, then it alters the sodium channel and ionic channel conduction properties, and you get the anesthetic. So that's the Meyer-Overton rule. That's a real basic rule for anesthetics. That may not be actually holding true as we get a little bit more sophisticated, but it's been a working theory for decades in anesthesia. Benzocaine works this way. It works by distorting the plasma membrane. So what do we mean? Most local anesthetics at physiologic pH are protonated. They are charged, meaning that they are in this form, and they are in an equilibrium back and forth depending on the pH and the pKa of the drug. Remember, the pKa is whenever it is 50% charged and non-charged. It is at physiologic pH in an equilibrium back and forth between this. It is mostly in a charged form, but it does, since it's in equilibrium, an equilibrium of sorts, maybe 95% here, 5% here, it is somewhat uncharged. So as this molecule associates and dissociates its proton, whenever it dissociates in a non-charged form, it can traverse the membrane. Now remember, whenever it's in the membrane, it can distort the membrane and cause sodium channel deactivation as well. But that's not the main function unless it is benzocaine. Whenever it's in its non-charged form, it will cross the membrane and go back into an equilibrium again, back and forth between the protonated and non-protonated form. Whenever it's in the protonated form intracellularly, now this 95% can act on the binding site intracellularly. Notice, even though we're highly protonated and charged here, we can't get across the membrane because of the charge. And it's inactive here because the active binding site is intracellular. So we have to convert to a neutral form, cross the membrane, re-establish an equilibrium back to a protonated form, and bind. So the lipid solubility is important, the pKa of the drug is important, and the size of the molecule as it traverses this membrane is important. So remember, I said how quickly the nerve is firing is important, and the size of it, and the myelination, and all of these things. So the type A fibers, the largest fibers that are myelinated, those alpha fibers are largest diameter, have the highest conduction velocity, and are less sensitive to local anesthetics. These are your motor fibers. Remember that the first thing to go is sympathetic, the next is sensory, and the last to go is motor, and the first to return is motor. That is a function to keep the system moving. You can go around with a numb leg, but you can't escape the predator with a dead leg. So although I'm not sure that local anesthetics were applied in an evolutionary sense, but that's neither here nor there. So these fibers are very insensitive to block. The smaller they get, the more sensitive they are, until you get down to these very small preganglionic fibers and C fibers that are very sensitive and non-myelinated. So the myelination makes them less sensitive. Here's the delta fibers that are small but myelinated. They are less sensitive to local anesthetic block than the larger C fibers. And here you see a view of that. Here's a large myelinated fiber with local anesthetic applied in a cartoon fashion so that you can sort of see that you're blocking one node of RON-VA here. Whereas a smaller fiber, like a delta fiber that is myelinated, this same amount of local anesthetic picks up the 3 nodes of RON-VA that are necessary in order to get conduction blockade. So this is one of the ways that large fibers that are myelinated are resistant to blockade, is because deposition of the local anesthetic must block 3 nodes of RON-VA to get conduction blockade to fail. Well, that's more likely to happen in a smaller myelinated fiber than a larger myelinated fiber. The potency and the systemic toxicity directly correlate with the lipid solubility. So the more lipid soluble, the more potent it is, and also the more toxic it is. So the more lipid soluble it is, the more likely it is to cross the membrane, get into the intracellular binding site, and bind avidly to that intracellular binding site. So bupivacaine is very potent and very lipid soluble. We'll show you a chart of that in a moment. And the duration of the action of onset of the local anesthetic is correlated with how quickly it redistributes. So the local anesthetic offset of action isn't due to local breakdown. It merely diffuses away because of its diffusion coefficient back into the system and is broken down either by the plasma esterases or by the liver. So you deposit it on a nerve, and the offset of it is how quickly does it just drift away or diffuse away. Now, these are tertiary amines and they are weak bases, which means that they are accepting and donating a hydrogen ion. Here it is accepted the hydrogen ion. Here it is donated it. So in its quaternary form, it has hydrogens on all 4 sides. 1, 2, 3, 4. Quaternary amine form. And in its tertiary form, it has donated it. So whenever it has the hydrogen ion on board on the amide molecule, it is in the active form. It is a charged molecule and ready to bind to the binding site. Whenever it is in this dissociated form, whenever the amide linkage is broken with the hydrogen ion, it is in its lipid soluble form. Hopefully I have beaten that completely to death for you. So at pH 7.4, most of the drug for local anesthetics is in this form. So it can't cross the membrane. So you've got to get it to the non-ionized form or the dissociated form here. So 10% can cross, 90% is useless. As with most things, 10% of the people do 90% of the work, blah, 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 however that works. So 90% of the local anesthetic molecules are useless and are diffusing away or are in the equilibrium, bouncing back and forth between charged and non-charged. You need to be able to be neutral or non-ionized across the membrane, and it is that positively charged side on the other side of the membrane that then allows you to bind to the intracellular binding site. The rate of onset then is related to the pKa. So if you can get more drug in its unionized form, more of it would cross, correct? So if it was a 50-50 mixture, you would have doubled your onset time. So the thought was, what if we add something like bicarbonate to our solution? Well, it turns out that doesn't work as well as you would think, because these drugs are intrinsically the packaging is acidic, and there's some things that really don't make it work as well as we would hope. But one of the physiologic issues is that tissues that are acidic or acidemic in nature affect local anesthetic binding. So when there's a localized infection and you have an acidemic culture because of a metabolic process, the local anesthetics are going to be in a more ionized form, and therefore if your pH is low in and around your area, if there's an infection in and around the area, the local anesthetic will be positively charged and cannot cross the membrane. Whereas at normal pH, you'll have some distribution. If there's ever a situation where you have high pH, then local anesthetics tend to cross. So in respiratory alkalemia situations, some pregnancy situations, local anesthetics are actually a touch more potent than you would expect. Inflammation tends to lower the pH, and thus local anesthetics do not penetrate well. For about 100 years, we've alkalized solutions. We've added bicarb to them to get them to work faster. But it really only changes the amount of drug that is in the unionized form by about 5 to 10%. So it does speed things up just slightly, but it's not a dramatic improvement. The rate limiting factor is, of course, how quickly it can cross the membrane in its unionized form. So what we're trying to do is take a local anesthetic from here and get it to cross this outer epineurium, this inner epineurium, through this perineurium and into the axon itself. So there's quite a bit of penetration that has to occur. But what you can do to overcome the speed of onset is put a higher concentration of drug in. So if I have 1/4% bupivacaine versus 0.5% bupivacaine, I have more drug in the unionized form here because the concentration is higher, and therefore the speed of onset is faster. But the toxicity and the density of the block will also be greater as well. You can do things like adding opioids to prolong and intensify the analgesia. So what do opioids do? Well, opioids act through a different mechanism. They are inhibitory neurotransmitters, and so they just decrease nerve firing. Whereas the local anesthetics block conduction, so they work synergistically through two different mechanisms, with opiates decreasing the firing at the synapse and local anesthetics decreasing the firing between the nodes of Ranvier. Whereas alpha-2 agonists also block by decreasing neurotransmitter release into that synaptic cleft. So these are synergistic ways of influencing the local anesthetic action. Also, local anesthetics, when applied to the membrane over time, in an extended period of time, like in an intrathecal pump, can begin to develop tolerance to the effect. So you get tachyphylaxis to the local anesthetic. After central neuraxial and peripheral nerve blocks with different anesthetics, it's not really clear how that occurs because there's not a lot of real financial incentive to discover new local anesthetics or how they work and that kind of thing. So from a finance standpoint, this is not a real hot topic. We just know that it occurs. The mechanism isn't really clear. So absorption of local anesthetics. Generally well absorbed from mucous membranes and transdermal sites. The blood flow deals with how quickly the drug is taken up and how quickly the offset is. Higher the blood flow, the shorter the duration of action at the nerve, and the faster systemic absorption, the higher the toxicity rates are. Remember, there is no local metabolism of local anesthetics. Absorption also determines the peak plasma concentration, and it is this peak plasma concentration that determines what? The toxicity. So the more vascular, the more drug. Some drugs cause vasodilation. Lidocaine causes more vasodilation, so it decreases its length of action. If you add a vasoconstrictor like epinephrine or phenylephrine, you keep the drug closer because the vasodilation is counteracted, so you slow the reuptake and the systemic uptake of the drug. These are also causes of local anesthetic neurotoxicity. Why? Because local anesthetics, ironically, are neurotoxic. So any substance that you apply that keeps them around the nerve longer will enhance the exposure to these neurotoxic chemicals. So epinephrine and phenylephrine have also been associated with increased regional anesthetic neurotoxicity. The vasoconstrictors like epinephrine and phenylephrine, they decrease the rate of systemic absorption. Therefore, when you add them, they don't get into the system as quickly, so you don't get toxicity as quickly. You don't get cardiac toxicity because it's not in the bloodstream. It's a slower release to the bloodstream. Increases the local uptake of the drug, and it can increase the duration of action. But we don't want to use vasoconstrictors in certain places. Toes, fingers, earlobes, genitalia, because it causes necrosis. So any place that has a tenuous blood supply, you don't want to do it. Now, local anesthetics will distribute to all parts of the body, including the central nervous system. And it's this distribution that terminates the action of the local drug. It's not metabolism peripherally. It is metabolism either in the bloodstream for esters or in the liver through the the P450 system. I almost said the P90X system. It's not the P90X system. It is the P450. Although, as I've heard from Dr. Elmore, CrossFit would be better than P90X anyway, and it's an ongoing discussion. But we'll let it go. Ester local anesthetics are broken down by plasma cholinesterases into PABA derivatives, and it is this PABA derivative that causes some of the allergy that we talked about. These are generally very short-acting, and they have low systemic toxicity, so that's why we use them on OB, so that even if there is vascular uptake, the effect will be short-lived both for the mother and the baby. And we utilize dibukane, which is a local anesthetic, ester-type local anesthetic, to actually determine cholinesterase deficiency. So a dibukane number of 80 is normal. So if it binds 80% to the molecule, if dibukane binds to your cholinesterase 80%, it is a normal esterase. Whereas if you get down to 40 and 20%, you have abnormalities. So you're going to have either cholinesterase prolongation or cholinesterase deficiency. So a dibukane number of 20 suggests deficiency, whereas a dibukane number of 40 suggests that you may have a longer acting neuromuscular blockade from your neuromuscular blocker. And that is the dibukane number, how avidly this dibukane local anesthetic binds to the cholinesterase. Whereas amide local anesthetics are broken down by the P450 system. They have longer duration of action because they're not broken down in the bloodstream, and as a result, they have more toxicity than esters. And here we see some degree of that, whereas procaine is lightly plasma protein bound, bupivacaine is highly plasma protein bound, which means it lasts longer. It is more lipid soluble. It is more potent because it is more lipid soluble. Remember, it is in the soluble form that it crosses the membrane, so more potent, has a slow onset due to pKa and protein binding. And it is the protein binding, avidly sticking around in the system. Once it gets in the bloodstream, it hangs around a long time. Once it gets onto the sodium channel, it hangs around a long time, which is why bupivacaine is more cardiotoxic than a drug like lidocaine, which is less plasma protein bound and less lipid soluble. So the toxicities are really just an extension of the pharmacologic action. So as more and more drug accumulates in the central nervous system, the more problem you begin to have. You first have CNS dysfunction, and then as the systemic concentration of the drug continues to accumulate, you begin to have cardiac conduction abnormalities. So whenever you begin, and this is a very important point, we tend to break this down into CNS, and then there's this big gap, and then you have cardiovascular issues. And it has been taught that way for quite some time because the original studies that were done in dogs showed that whenever you started giving an infusion of local anesthetics, one plasma concentration caused a CNS effect or a seizure, and a different plasma concentration caused conduction abnormalities and cardiovascular collapse. And so we kind of got this idea represented that you've got CNS toxicity and then nothing, and then you get CNS or cardiovascular toxicity. Whenever in reality they are a continuum. When you first start to have CNS symptoms, you have some degree of conduction blockade in the cardiac system. So the thinking now is to prevent cardiovascular collapse, you should aggressively begin treating local anesthetic toxicity at the introduction of CNS symptoms. So if you start having CNS symptoms and it progresses to the light form of a seizure, you probably are to be giving intralipid and having epinephrine as a support to the cardiac system before you reach total collapse. So any CNS toxicity, you should be thinking immediately could progress rapidly to cardiovascular toxicity. There's not this window of safety that we've kind of traditionally taught. And the intensity of the toxicity is based on the blood level, because local anesthetics are absorbed into the bloodstream. and the metabolism is slow. All right, so here's some information looking at local anesthetic concentrations producing cardiac arrest in dogs. Notice, so I apologize, these were created on a Mac, and so the PC has done some things to the slide background. But we have a square here that is the total local anesthetic and the free local anesthetic. So remember, bupivacaine is highly protein bound, so very little of it is free. So the total local anesthetic that causes cardiovascular collapse is very small here for bupivacaine. Levobupivacaine is less potent, so it takes about double the amount of free levobupivacaine to cause cardiovascular collapse, whereas ropivacaine, it takes about 5 times the amount. So ropivacaine is not some magic solution that is less cardiotoxic. It's just less potent. It's a less potent local anesthetic than bupivacaine. It's less potent because it is less lipid soluble. It is less protein bound. It just works less well. And so they actually marketed this in a really interesting marketing way. They said ropivacaine has sensory selectivity. Well, it's not magic in that it doesn't bind to motor nerves and it only binds the sensory nerves and you know, is imbued with special properties and qualities that make it special. It's just a less potent drug, and because it's a less potent drug, it is less motor blockade and it has less toxicity. And notice lidocaine, because of its relatively less potency, because of its less lipid solubility and its less protein binding, is less cardiotoxic than bupivacaine. See that? Excellent. Now, bupivacaine is also more cardiotoxic than levobupivacaine or ropivacaine. You knew this, but here's some of the data behind it. So notice that the 3 drugs, bupivacaine, levobupivacaine, and ropivacaine, cause seizures at a similar level, but they cause arrhythmias at very different levels. So not much more bupivacaine is required to move from seizure to arrhythmia to frank asystole, whereas quite a bit more ropivacaine is required to move from seizure to arrhythmia to asystole. So basically, if you triple the amount of bupivacaine systemically, you will be at asystole, whereas you have to go up by a factor of 7 systemically with ropivacaine to get to asystole. So this reinforces the point that I'm making. One progresses rather quickly from seizure to cardiac symptoms. So whenever you first see CNS effect, you need to be treating, because once we get to this area, patients often don't recover from this, because once the cardiovascular system is collapsed, it's very difficult to get the bupivacaine or the ropivacaine or the levobupivacaine off of the sodium channel. The system kind of freezes up. You have to go into cardiovascular support. So the oral board examination question is, you need to move to cardiopulmonary bypass. But the last time we checked, that wasn't highly available over at the Gill. Although it seems like it sometimes whenever you go into the anesthesia attending room, after 2 o'clock, it kind of looks like there are several of us that are on bypass. But that's a different issue completely. CNS symptoms progress rather quickly through vertigo and tinnitus into ominous feelings. If you're on OB and you're giving your test dose and the patient starts saying, "Oh gosh, something doesn't feel right. Oh my gosh," that feeling of foreboding. Do not ignore that. That is them telling you they are feeling local anesthetic in their system and they don't know how to say it. Then they can start to get very, very talkative. They'll get almost panicky. And then that progresses rather quickly from that into convulsions and CNS depression. People can pass out. If you get to this place, keep in mind that you do, by definition, have local anesthetic toxicity occurring, and it can move to cardiovascular quickly. Okay. The more acidotic they become, the worse the local anesthetic issues will become. Pregnancy lowers the dose and the concentration, meaning that you'll have convulsions at a lower dose because of a whole host of issues having to do with being just slightly more alkalemic, and that sort of thing. So keep in mind that you need lower doses with pregnancy. All right. CNS is more sensitive than the cardiac system, and I've just kind of gone over and over this. Cocaine gives you a feeling of euphoria, and so it's a little different kind of thing. Lidocaine is used as a sedative, and so it can cause toxicity and sedation even at non-toxic doses. The hypotension, you get a pronounced and diffuse arterial vasodilation and conduction block, and this is because of the sympathetic activity that is blocked, in addition to the CNS depression. One of the things that has come out of the work by Guy Weinberg and ASRA is if you start to see CNS toxicity, you might want to think about using very dilute epinephrine, 1 to 2 micrograms per mil, just to keep the systemic vascular resistance up and to keep the cardiovascular system supported. So maybe even a 10 microgram per mil solution, just giving little boluses of it. So whenever I was doing more regional anesthesia in 2010, I always had a little epinephrine ready to go, but you got to be careful not to give it by mistake. That's also happened. But having that available where you don't have to draw it up and run and get it because you don't have much time when that occurs is key. The main problem is arrhythmias, which then progress to asystole, decreased conduction rate, become more acidemic, more hypercarbic. It becomes much more difficult as this systemic vascular resistance decreases to then resuscitate the patient. Another problem is methemoglobinemia. So some local anesthetics, pilocaine, benzocaine, and lidocaine mainly, have been associated with methemoglobinemia, which binds to the hemoglobin molecule, converts hemoglobin to methemoglobin. You'll have impaired ability for oxygen carrying capacity, and that is treated with methylene blue. So this was really pronounced with benzocaine. So we would slather people's mucous membranes with benzocaine for awake fiber optic intubations, and occasionally would start to see SATs drop down into the 80s. We would think it was sedation, but it was probably the benzocaine methemoglobinemia. Allergic reactions are fairly rare. Most are with esters because of the PABA metabolites. Rarely with amides. It's very, very rare, and the cross-sensitivity is virtually nil. I've seen a couple of patients that have true anaphylactic reactions to lidocaine. Both of them were implant patients, and they had testing at a dilution of 1,000, and still had reactions, but it is very rare. Usually it's an intolerance from a dentist. They had epinephrine in the local anesthetic. The heart started to race, and the patient got a little jittery, and but a true anaphylactic reaction is very rare, and it's usually an anaphylactoid reaction, usually from the PABA. There are other things that contain PABA. I'm not going to talk about them. All right, so study done in 1979 looking at local anesthetic reactions. Okay, so did they have anaphylaxis, or did they have another type of reaction? So 90 patients, 0 out of 90 reacted to local anesthetics that were diluted. So that suggests right there that it is an anaphylactoid issue, because parts per million cause anaphylactic reactions because of the immunologic memory that is imparted from IgE to IgG conversion. So the fact that diluting the local anesthetic essentially did away with the percentage of local anesthetic reactions suggested that you have very few truly anaphylactic reactions. Okay. So the undiluted forms had more instances of anaphylactic or anaphylactoid reactions. So most were thought to be anaphylactoid, though the diluted forms, once we diluted it down, the incidence of local anesthetic allergy really started to dissipate. Local anesthetics can also cause concentration-dependent nerve damage. So they're neurotoxic. So those things like epinephrine and phenylephrine that keep them around nerves to prolong the block are also part of the mechanism that causes neurotoxicity and issues. One of the biggest problems that is traditional, although not much less an issue today, is something called transient neurologic syndrome or Cauda-Equina syndrome. It's found to be in obese patients in ambulatory surgery in a lithotomy position using high concentrations of local anesthetic. So you had a large person that had positioning problems, so they were already at risk for neuropathy from positioning. You utilized the local anesthetic in a high concentration because they wanted it to work quickly and go off quickly. They were often in a lithotomy position, so there was maybe stretch on the sciatic nerve, and all this put the stretch with the positioning ischemia with the high concentration, so you get fast onset, all resulted in transient neurologic syndrome, which was a saddle, Cauda-Equina syndrome with burning in a saddle distribution coming on within 24 to 72 hours after the application of the local anesthetic, and often not resolving for 2 to 3 weeks. And with using lower concentrations of local anesthetic and more awareness, this has essentially gone away. They were using 5% lidocaine for it. Ester local anesthetics. Cocaine is one of the esters. It is a Schedule II substance. You don't want to use epinephrine with cocaine because they're both vasoconstrictors, and you'll get a Lynn bias kind of situation. They already have quite a bit of cardiac toxicity. It's not commonly used. Anytime that you have an ENT that is using cocaine as a vasoconstrictor for surgery in the nose, you need to very closely monitor your EKG. As a matter of fact, I would recommend anybody who's having ENT surgery, even if it's outpatient, have a 5-lead EKG if they're planning to utilize cocaine as the vasoconstrictor in the nose. Benzocaine, it acts mainly through acting in the plasma membrane. It causes methemoglobinemia. It is a topical anesthetic. It is not a very effective injectable anesthetic. Prilocaine, topically it is ineffective, not effective topically. It's used for spinals and for short cases. You can use some epinephrine to prolong the effect, but procaine and chlorprocaine are very short acting because of the redistribution, and they're broken down in the plasma. Tetracaine, same thing. Amides, lidocaine, most commonly used local anesthetic. It's effective no matter how you give it. It's very potent, rapid onset. It has some sedative effects. It also can cause some methemoglobinemia, less so than prilocaine and benzocaine. Bupivacaine, it's lidocaine that knows somebody. Bupivacaine, it has no topical effect. Slow onset, very potent, very lipid soluble, a lot of plasma binding, and because of that, it has the most cardiac toxicity, more cardiotoxic than the others. It is used for sensory analgesia with minimal motor blockade. Ropivacaine, it is a less potent enantiomer of bupivacaine. It has not got magical qualities that make it less sensory effective. It is just less potent, and because of that less potency, it is less toxic, and it is more sensory selective. Imlacreme is a eutectic mixture. That means we put two substances together in equal quantities by weight. It's a eutectic mixture. And the lidocaine and the prilocaine becomes an oily mixture, and it is applied to the skin. It is a topical anesthetic used to start IVs and to minimize cutaneous irritation for people who don't want basically to have a trans or an intradermal injection of local anesthetic. There are some drugs that are used for local anesthesia that have local anesthetic effects. One of the main ones is, and it's not listed here ironically, is Demerol, meperidine has local anesthetic-like effects in that it increases sympathetic nervous system outflow, epinephrine and norepinephrine, prolonging local anesthetic effects. So if you give meperidine in combination with local anesthetic, it will enhance spinally the local anesthetic block because it increases epinephrine and norepinephrine in the synaptic cleft. So, and it also has some weakly local anesthetic properties, as does propranolol and corticosteroids to some degree. And that is the end of our lecture. Thank you very much, and I hope it was worthwhile for you.